and welcome to the EMS Handoff Podcast. This is David, and along with my co-host Eric McCullough and Bradley Dean, we are your source for all things EMS. Tonight we bring on a guest. We've actually been solo for the last couple weeks, guys, and this week we're bringing a guest on here. I think we're going to have a great topic, but before we do, you know, we always like to check in. Eric's always doing the adulting thing. So what's the weather been like, Eric?
Oh, it's good enough to have a bonfire finally.
Oh, wow.
Yeah, I mean, not great. I mean, it was still a little warm, but I was like, dadgummit, I'm having one. I'm not, because we're not going to have a fall. I've just decided that. We're going to get 5 days of fall, and then it's going to be followed swiftly by a kick in the teeth to winter. We're not going to get anything but summer mosquitoes and just cold weather, because Tennessee's become awful about weather.
Wow,
at least in my area, Middle Tennessee, not Knoxville.
Just tell us how you really feel.
Yeah, I know. It's so frustrating because I want to enjoy it. You know, I just want to enjoy it.
I mean, you could go out to Arizona where they only have hot and cold. You know, it's really.
Oof, no. So,
all right. So you're gonna keep your Middle Tennessee weather then, huh?
Yeah, I try. Yeah.
All right. And so on the other side, we have the vanishing Bradley Dean. You never know when he's going to come up with a Houdini and rush out, but he's keeping the people of North Carolina safe tonight. Bradley Dean, what's going on, my friend?
Yeah, it's funny how you said Houdini there. So, but anyway, so I'll try not to vanish, but man, it's been a great day. The weather was wonderful here, but it's funny we always talk about the weather, but I will tell you that fall colors are starting to come out. It really looks beautiful between here and the mountains.
You know, one of these nights we're going to just have to have somebody on from the National Weather Service just so we can do a whole episode, because that's what we always seem to talk about. You know, that's the adult thing. It's like, hey, guys, how's the weather in your area? This is great.
Yeah, right now, everybody who knows us at this point listens to us, like John Wood and a few others, because he was listening to it last night. I'm like, they're fast forwarding the first probably 5 or 10 minutes of this. They're just
it's sometimes the best. It's like, oh, there they go. They're still
okay, there they go. When they're going to shut up
goodness.
about that and get on with good stuff.
All right, before we get started, we always like to thank our podcast partner, the Journal of Emergency Medical Services. See, Eric, we'll go right on past that weather stuff, you know. But the Journal of Emergency Medical Services has been a great partner to the EMS Handoff since our reboot time. Make sure to go by and check them out at gems.com. They have all the industry news that is news. Plus, they have all of our episodes. You can go back, and I actually went back and tracked every single one of our last episodes. We rolled over that half-century mark here recently, which has been pretty awesome. And so we love all the support. We're almost at a year, guys. It's kind of hard to believe that, but we are. So you can check us out on gems.com and find out everything that's going on. Don't forget to go to the Pursuit Company and find all of the EMS Handoff merchandise. Tonight I've got the subdued black on. One that everybody likes. You can see that EMS Handoff in the background. Our Keep Back podcast line is one of the most popular we have. You can go by and check all of those out at thepursuitco.com. That's enough of that tonight. Before Houdini vanishes, go ahead and introduce us to our guest there, Bradley Dean.
So tonight we have, a great guest, and I'm sure that many people in EMS are familiar with the stuff that he has done, his writing. Tonight we've got Mike McEvoy, who is the EMS Coordinator in Saratoga County, New York. He's a paramedic. He's a nurse. He has a PhD. He's got all the wonderful letters behind his name. He does a lot with the resuscitation committee at Albany Medical Center. So I'm going to turn it over to Mike, and I'll let you kind of fill in anything there.
Sounds good. I'm happy to be here. Good to see everybody. You kind of nailed all my occupations there. So I'm a paramedic, a nurse, an author. I do a lot of speaking. So I kind of divide my time between pre-hospital and hospital stuff. And then hospital, I work as a nurse in a cardiac surgical ICU, which has two components, adults and kids. And so I see a lot of the ECMO and the fancy sort of stuff that we read about all the time in our EMS magazines, and we're hoping comes out to the field someday. So that's sort of my background in a nutshell. Yeah. And I imagine people have seen me in the EMS world, the fire service world, and in the healthcare world as well. So
one of the things that I noticed is that whenever we bring a guest on here, we go through the biography, and I'm sitting here going like, how much time do they have in their day? Last time I checked, I have 86,400 seconds. And for some reason, it seems like I don't have time to do all the stuff I've got to do, let alone, listening to all that you got going on, Chief. But thank you for coming on the show. And in respect of those 86,400 seconds, we're going to go ahead and rock and roll in this conversation. I'm just going to go ahead and put you on the spot. As we reached out, I said, hey, what do you want to talk about? You said the very first thing, you have the date that the pandemic is going to end. I think that's exactly how that first part was worded. So everybody can hear it first. Chief McEvoy is getting ready to lay down the line when this pandemic is going to end.
Wow, I wish I could predict a future like that. And I guess that, like, I think most people by now have realized that it's not going to abruptly stop. It's kind of funny because this is our third novel coronavirus, right? And SARS, the second one just disappeared overnight. And I think a lot of people who knew about that were hoping this one would disappear overnight like that as well. And it kind of looks as though, well, that's not outside the realm of possibility. It seems like it's getting legs to continue itself for another couple of years, and maybe it'll become something that hangs around forever like the flu does.
Well, this is one that I have to admit defeat on, because I was asked in January of 2020 if I thought that this new SARS-CoV-2 was going to do anything here in the United States. And I said, if it makes it here, because I was going on the trends of SARS-CoV-1. I'm like, no, it's going to be here. It's going to go away. And, chances are it's never going to do anything. And then about 6 weeks after that, our campus is closing for a second week of spring break. We don't bring anybody back for a month and a half, almost 2 months. And after that, it's been a big deal. But, with that, I think that question loads a whole lot of things. So at some point in time, we go through kind of the emergent phase. And as you mentioned, it goes, if it continues and what a lot of people think, and we kind of see this as something like the flu after that, something that we see throughout. So where do you kind of see, based on your knowledge and your research, where do we see this going after the constant surge up and down?
Well, I guess, like, it's sad in a way that we continue to hold the record here in the United States for the number of infections and the number of deaths worldwide. And I think there's other countries right now trying to sneak up on us with that, but no one's beat us in the last year. And I think based on that, the fact that we can't get the kind of vaccination that we need to wipe this thing out, that we're kind of going to have to live with it in our country, at least for a couple more years, I would say, until we get to a point where either enough people have been infected with it and or vaccinated. And we've been successful in eradicating a few things over time, like smallpox and measles, and this probably falls right into that category where we got to reach that critical threshold, and it's just not going to happen based on what we're seeing in our society right now. So that, I guess, too, the United States is like a whole bunch of little countries, because we have places where it's a big problem, we have places where it's a little problem, and we have places where it's a moderate sized problem, and that's directly related to behavior in those states and in those communities.
And I think you're absolutely right. And the way you're talking about it is the fact that, there's been many things that have affected us here in the country, across the globe. And some of them we just end up turning around and living with that throughout history, such as the flu. There's been the variations, the Spanish flu, et cetera, back in the 1800s. But when we take a look at something like this, it really does kind of shift how we do everything. And so let's talk about the EMS profession specifically, and what changes. We've been sitting here now for 20 months, 19 months, right at 19, 20 months. We're in that range. And we've seen a tremendous shift in EMS. So what are some of the changes that you've seen in EMS that have come about because of the pandemic?
Well, the two big ones that jump out at me are, I'm a nurse and a paramedic, and so I guess I should hate myself. The relationship between nurses and paramedics has never been a great one, socially or in their interactions. And I think that has dramatically changed because paramedics have been pulled into public health. And I know in my own county, the relationship between the two, where paramedics have really gotten some insight into what nurses do and working with nurses and immunization and testing clinics. And nurses have looked at what paramedics do and gained a whole lot of respect for them as a profession. So that's one thing that I think is big, for us as EMS people. And I think the other one, which if you think back to Ebola, I had such a problem when we were dealing with Ebola here, and not that we had a lot of cases, but New York was an entry portal. And so Ebola was a big thing, and we had to figure out a way to handle patients with suspected Ebola, and no one wanted to have anything to do with that. We had to form a team of the few interested people in the county who were willing to put on all the gear and go out, pick up an Ebola patient. And, out of 1,700 some providers, I had a little group of 30 that were willing to do that. And now we flash forward to today, and we have learned so much about PPE and infection control that most EMS people would be like, you could name any problem that you might encounter, including Ebola, and EMS people would be like, yep, I know what to do. So our whole education on PPE and infection control has just overnight become something that we feared to something that we can handle now. And I think that's impressive. I mean, we probably even can recognize things that we shouldn't be buying because they're a waste of money. I give people credit for learning about that.
Well, and they did it. One of the things about the EMS profession is we're extremely resilient. You place us in a situation, we're going to learn and we're going to adapt and we're going to do what we have to do because, in the end, we're out there to help the community, and that means we have to be prepared. We have to be ready to use that equipment. And I have seen that, in a setting, just had another fit test for an N95, and everybody's like, these masks, we should just get rid of these and go to the other ones. And, because like you said, they're starting to identify, but I want to go back to the number one point that you said under that. And it's kind of the change between, or the shift, I guess, in the mentality between EMS and nursing. As you mentioned, we've gotten extremely close, and it's quite interesting. I had multiple conversations that there's a lot that just have really said, we never understood just how much that you all could do. And one of the things we're seeing in our area that's actually changing that even more is the fact that multiple hospitals are actually hiring in EMS providers into their emergency department to fast track some of the cases that they have come through because of kind of their autonomous nature. They're still working with that physician or under that physician, but they're utilizing those skills and processing while the nursing staff are in another area. So they're actually getting a little bit closer relationships. So, a lot of when we take a look at how our federal system acts, we all sit under ESF 8 for healthcare. And this is kind of one of those areas that's been tested. And for the most part, we've seen a influx of those federal COVID dollars that have come in and kind of hit as well. And so some of the things that I've seen, and I'm just going to kind of push your direction as well, looking at the field services that you deal with. We've seen a lot of COVID funds come in for inclusion of UV lights in the back of the ambulances or disinfectant sprayers and stuff like that. But I think there's been a lot of conversation about, have we properly been disinfecting our units between each patient anyways? And so, when it comes to operations, like, what are some of the things that you've seen change during this time as well?
Well, I guess, I think there's a few things that I see that are big issues. One is we've never really in the past had a need to get reliable information from our dispatchers. And we've been willing to okay, let me see. It says a cardiac, so it could be anything from a asthma call to a stabbing. So I'll just go. We've demanded that now in the last year and a half. We want questions asked, and we want to know when we're walking into something that's potentially an infectious problem. And we found all kinds of creative solutions. As you said, EMS is very creative, and so are our 911 centers. We found all kinds of ways to operationally be better informed about what we're rolling into. That's an interesting thing you bring up about the disinfection, because I'm taking part in a national study that's the expert groups meets tomorrow for the first time to talk about how we decontaminate things in the pre-hospital environment, and whether the techniques and strategies that we're using are number one, consistent, and number two, actually evidence-based, so that they affect the outcomes of the people that we're transporting. And this is like a huge conundrum in the hospital as well, because hospitals had no idea what to do to clean a room after a COVID patient left. And so they used all the hydrogen peroxide, the UV lights, and burning everything in the room. The strategies were from extreme on one end to none on the other end. And I guess one of the tenets of infection control is just because you have contamination on a surface doesn't mean that you have infection necessarily, right? I mean, you could have bubonic plague all over the back of the ambulance and might not get anybody sick in the process unless they're licking it.
We're not going to leave that out of the realm of possible either. So.
Yeah, right. Yeah, exactly. Yeah. So I think that's been an interesting change in how we operate is the preparedness and the information that we're getting. I think the other thing that I see amongst EMS people is that people working together have become closer to each other. Like, I see a little bit more community support inside our organizations, and that's been interesting in a way, because it's been very, very stressful year and a half, and you could see the fallout that's happening across the healthcare spectrum, where nursing homes lost a huge number of their staff, and hospitals have lost tons and tons of staff. EMS seems like it hasn't been affected as seriously from the perspective of morale in the services as has happened elsewhere in healthcare. And I wonder if that's because the skills that we have along the lines of resilience, which you mentioned earlier, are stronger in our line of work. I don't know the answer to that. I said very early on in the pandemic, one of the things I talked to our public health people about was we have like two different responsibilities, two different levels of responsibility. If you go back to the HIV era, a nurse or a doctor can refuse to take care of a patient who has some condition or has some sort of situation where they don't feel like they either want to take care of that patient or it's safe to take care of that patient. So everything that they do and everything that they did in the HIV era was premised on whether or not they were willing to take care of those patients. And the same thing's true during COVID. They can refuse an assignment that they don't think is a safe sort of situation. We don't have that luxury in the fire service. We don't have that luxury in law enforcement. We don't have that luxury in EMS. So we're assigned to a call and we go to that call or we go home. And if you think about that, imagine the downstream psychological effects that has on those two different workforces, right? And I think because we're required to do whatever comes along, maybe our resiliency has been stronger during this pandemic than it has elsewhere in the system. I don't know the answer to that. That's a casual observation.
Well, and that kind of goes into our next area anyways. And I want to revert just a little bit. We were talking about licking stuff in the field. One of the most telling questions when they started to put all this stuff out here, we're using the sprayers, we're using the UV lights. And I said, so how are you getting everything on the inside of your first in bag? Well, it's sitting back there. I'm like, yeah, it is. Would you open that up? You're talking about it being on everything. And they're like, I don't know. And so it's been, it's no secret that, one of the conversations that we've seen and actually seen it for a few years is the amount of nursing staff that is out there. When we take a look, it's nursing, it's even physicians have had shortages over the last several years. And so in the hospital, we've seen those numbers kind of affect. What have we seen about that kind of staffing level issue in healthcare bleeding over into the EMS side as well?
Well, it's definitely there. And, it's, I would be wrong not to say that we have a crisis in our EMS world in the workforce. I mean, we don't have enough paramedics. We don't have enough EMTs to fill the openings that are out there. And, that's what we were talking about this offline earlier is, what are the sources of that? And it seems like New York State did a study on it in their state, and it really fell down to two things. One was the culture in the workplace, and people leave because of their workplace and not because of the calls that they're running. It's because of their management, their leadership. And so that's probably half of the problem. And the other half of the problem is, what are people paid and how are they compensated and what do they need to do to make a living? And, if somebody, as we talked about earlier, if a hospital is going to pay a paramedic $10 more an hour, well, then it'd be kind of foolish not to go work somewhere where they can make some more money. I think the state of Texas did a survey they took all their licensed providers in the state and they ran it against their PCR database to see how many of the people actually saw a patient in the last year. And it was stunning. It was probably about a third of them actually saw a patient. So where are the other 2/3 working? And the answer is not in 911, I guess. So
I always thought that was interesting that I would ask students, I saw them on the entry level, obviously when they were coming into EMT and AMT school. And I was like, you might've gotten in here for passion, but you stay because it's a business. It becomes a business. It becomes transactionary because you don't see nurses and doctors and stuff. They don't, and PAs and MPs this is very much a business transaction. What they do at a clinic, they will go from a hospital to a clinic on the side based on their compensation rates. That's one of the top things they think about. It's bizarre kind of working with physicians because the way that they talk and the way that the nurses talk is way different than the way paramedics talk. Like we talk about shift, call volumes and stuff, and money becomes something way down in our priority list whenever we're discussing, but it's actually the top priority when we go home because depending on how far down you are on your own monetary level, you may not get to come home that often, and it may start to weigh heavy on you. I keep saying that, like, if I had to go back into a program again, I'd Dave Ramsey them for an entire day, just so that they guys don't make bad money decisions because your passion will become more money a lot sooner than it would naturally. And so do you think that that's evolved even more like now? Because now you got nurses with higher travel pays, and you got paramedics who are like, these hospitals are willing to see these paramedics, and they're just willing to suckle them into the ER and pay them, like you said, more money than they're making on the ambulance.
Yeah, I mean, that's definitely drawing people away from the workforce in the street, So, but I think I would say that it's if I take my own area where I live here, the service that I work for and at home is a busy service. So it runs, 7,000 calls a year. Well, I call that busy. I come from New York City, so that wouldn't be busy there. But so here it's busier. It's probably the busiest service in the area. And people have a choice of coming to work in the place where I work or working at any one of a number of places around here for roughly the same amount of money. So you take your choice as to, do you want to sit and watch TV? Do you want to run calls most of your shift? And it's funny because for the same amount of pay, there's less problem hiring people, less openings needing to be filled in a place like mine where people really enjoy the work that they do and they really enjoy each other. And yet they could go somewhere else where it's easier for them. Yet they choose to go somewhere where the environment is an environment that they like. And I think I don't know that we really have seen the tip of the iceberg with that yet nationally, because, there are, I think if you looked at every single service and you figured out a way to quantify what that workplace environment is like, you'd probably find that that plays a major factor in being able to recruit and retain. Retain, I think, is the key, because that was what we were talking about with the National Registry data that I threw out publicly a few weeks ago. Is that data shows two big things. One, we're not producing even half of the number of EMTs and paramedics that we need each year. And number two, it's not that they're failing out of school, it's that they're failing out of work. Once they graduate and they go to work somewhere, we're losing them. And we're losing them because of what? I don't know. When you ask them, they seem to say leading the list of reasons they leave is their management. So it's not their work.
Well, it's quite interesting, and you may have read it as well, Chief, but dissertation was done down in Georgia, and I believe the individual is now the state EMS director, but the Georgia Trauma Foundation actually sponsored his dissertation, and he actually did a study, the Georgia EMS Workforce Study is what it was called, and the individual did exit interviews with anybody that was leaving the profession or was just simply transferring service. And he kind of spoke about several of the main points, or really kind of listed out the main points. And money, well, for the most, was in the third place spot. And so we kind of take a look. And so one of the LinkedIn groups that I follow is one called Leadership First. And there's a Gifford Thomas wrote a book by the same title as well. And it's really interesting. And you take a look, and a lot of it is put back on that leadership. Does that leadership allow a toxic environment? Does that leadership show favoritism? Does that leadership show that the person is valuable? And I think, it's one of those things that we got to a point there between 2001 and 2011, between the individuals that were coming into the profession after the September 11th attacks, and then subsequently right after that, the economic recession, that everybody wanted to come to the profession, and we had tons and tons of people. And now we're having to compete with the likes of different services out there that are going, hey, we'll pay. We've got bonuses. We've got moving travel allotments, and you come down to our service or come to our service, we'll absolutely bring you in, pay you. But then we also have other places like, Hobby Lobby in the area is competing dollar for dollar with the paramedics. And, one of the things is you go into your 8 hours and you're done for the day. And you don't have to worry about, the tragic call that you're going to run or the fears of, not being able to go to work for the next 10 days if you happen to test positive for COVID and such. So I think the data that you put out was tremendous. And we're going to shift there for just a second since you went ahead and brought it up. We take a look, and one of the things that you addressed, one was obviously you hit all three levels, EMT, advanced EMT, and paramedic. Got into the numbers as far as people completing programs, testing, and then, as you mentioned, kind of the retention side of things. And I like how you put it, they're failing out of work. And you put a specific quote in there that they were leaving the profession 11 times. The paramedic level was leaving the field 11 times greater than that of those individuals that weren't able to pass the written examination. So now we got to kind of back up and leave New York, leave Knoxville, leave Murfreesboro or Rowan County and look at EMS globally. And, where do we need to, I really guess, put our efforts? We talked about leadership, but where does that leader, especially new leaders, start to say, hey, I want to create the destination job? And I think that's, let me quantify that one more time. Whenever we do our paramedic interviews, one of the questions is, what is your long-term goals? And it always seems to be, well, I want to go to paramedics so I can get to nursing. I can go to PA. I can become a physician. I can go on the fire side. And then you have the occasional that says, I want to stay in EMS and, become a supervisor, become a director, et cetera. So if you were bringing on or mentoring your next generation, how do you tell that individual, say, hey, this is what you need to do to make EMS, and specifically your agency, a destination job? Some place is going to keep them for 10, 15, 20, 30 years.
That's a good question. While we could blame management and leadership, we can also say that, if I compare EMS to the fire service has a very, while we don't always agree on it, we have a culture where company officers, those people that are in between the chiefs and the guy, the boots on the ground, the company officers have a very deliberate process by which they acquire the skills that they need to lead a team of people. And you find in fire departments that when there's a good company officer, there's a good company. That's a good station. And so I would say one of our big issues, if I was going to try to create the perfect world in EMS, is I would focus a little bit more on standardizing that sort of leadership skill set, that middle management, the supervisor. We don't even have a term for that person in EMS like we do in the fire service. And I think that's that's always been a weakness for us, is trying to train that middle person. And even hospitals have preceptor training and charge nurse training, so to say, which helps them, gives them the skill set that they need to create a good working culture in that place where the people are delivering care on the street. And I would say that's probably the first thing I would think about. I guess the second thing is how much training gets done. And again, a really good firehouse does a whole lot of training. And I noticed that a really good ambulance service does a whole lot of training, and people are passionate about training and passionate about what they can learn when they have downtime. And we have a lot more downtime in EMS, believe it or not, than other sectors of healthcare. And if we use that, we invest money in what we're doing to improve the technology and have simulation, that sort of stuff, and then have people trained to use it and take advantage of it. That seems to also be a factor that retains people. They feel as though what they do is valued by their employer and they want to invest in them doing it better. So those are probably two things that I could think of right off the bat that I would say are important.
I'm gonna tie this. So one of the few hats that you do wear, you sit as the EMS section chair of the International Association of Fire Chiefs. And I, believe it or not, have this little document sitting on my desk right now that you probably can tell exactly what this picture is. And I take a look, it's IAFC's Officer Development Handbook. And, it's kind of interesting when you take a look. If you were a service chief or a service training officer, anything in leadership with a service, the question is I come up to you and I say, hey, I've been an EMT, an AMT, or a paramedic for X number of years. What should I be doing? And, the idea really kind of comes to mind. Well, keep up your licensure every 2 years and, go out and do whatever. And, I kind of like the quote that's right above that chart right there. Professional development is the planned progressive lifelong process of education. And, it's one of those things that probably most of us on here have experienced. Is like, well, why are you going to paramedic school? You're not going to use that. And, I came up through the fire side and like, they're just going to use you. They're not going to give you any money and you're going to go to the worst stations, et cetera, and it's like, well, I'm going to grow. I'm there to help, et cetera. It's like, well, why are you going to get your bachelor's degree? You're never going to use that in the fire department. It's like, you don't need a bachelor's degree to put wet stuff on the red stuff. But, it was that desire. And of course, obviously, when I hit my master's, they're like, are you stupid? I was like, no, actually, thinking kind of smart. That's why I'm going to get the next level. But it's kind of like, where is that with EMS? And, you have that 2 year, that 3 year paramedic that's looking to do more. Where do we kind of guide them? In this, it's saying, hey, at this level, you should bump up to this, look for this certification or go for this degree requirement or, et cetera. And so I think that may be one of those beneficials. And it goes back to that workforce study, that kind of knowledge or investment into developing a plan like that will tell your people that, hey, I value you and want to keep you here. So we shift this conversation back. We took that rabbit hole down the trail. We've got a couple more questions here about the COVID pandemic and really kind of where things lie. So the question kind of put out there, what mistakes have been made at each level and where are they as far as can we pull them back and change and be on a better trajectory as a group?
Well, the three big mistakes that pissed me off the most were the first is that even today, the CDC continues to insist that fever is a symptom of COVID that we could use to identify it. And so we're taking temperatures, walking into buildings completely and totally needlessly when the evidence would seem to suggest that fever is probably the last symptom that you could use reliably to diagnose COVID. So I'll skip on to my next one. The second one is we were told in the beginning by the CDC, and they've since changed their mind. This past summer, the CDC admitted in June that surface cleaning is unimportant in the spread of COVID, that really hand washing is the important thing. And here's how they realized that. In May of this year, the poison control people reported to CDC that there have been a 700 times increase in poisonings from cleaning products that people have been using to disinfect their work surfaces, their doorknobs, and everything under the sun around there. And it didn't seem like it was getting rid of COVID. So maybe it was a little overkill on the surface cleaning. So that's the second one. And unfortunately, that's kind of changed. But in the mind of the public, maybe not so much, because I still see people wiping off their chair when they get in the airplane. Then the third one, which I think no one wants to take responsibility for this, but in the beginning of the pandemic, despite evidence to the contrary, the CDC insisted that we were spreading COVID by droplets. And so 6 feet distancing was what we needed for social distancing. It was people sneezing these droplets, and that was what was spreading COVID around. It completely debunked any idea that it was aerosolized virus. And then now the evidence is overwhelming that it's aerosolized and that it stays in suspended particles, stay in a room for an hour, 2 hours, 3 hours, and people walk into that room and inhale suspended particles of aerosol. And it's funny because I talk to dentists groups a fair amount, because a training company that I'm involved in does a lot of ACLS and PALS training for dental practices. And so I talk to dentists a lot. And very early on in the pandemic, they seemed to get this idea that if they had a choice of things to do in a patient care area, and you want to talk about aerosols, there's dentists, right? So they got the idea very early on that if they put a machine into their room that filtered the air, that they were going to have a much better effect on keeping their employees safe than anything else that they could do. And maybe they combine UV with that HEPA filter or that aerosolization filter. But that is interesting because they understood the problem. And I think they understood that we're not talking about big droplets. We're talking about aerosolized things. And you think back to measles. Measles is so infectious, not anywhere near as infectious, so much more infectious than COVID is, that somebody with measles walks into a room and for 3 hours after that person leaves, any unvaccinated person that comes into the room is going to get measles 90% of the time. So now we see, okay, that's how COVID is spread. And boy, that, if that information was pushed out when the data started to point to it, we probably wouldn't have been in the situation that we were for so many months, last year.
And so it's actually kind of interesting. One of the podcasts that I listened to on this, actually from up in your direction, is a podcast called the Osterhome Update. A guy named Michael Osterhome, who's director of the Center for Infectious Disease Research and Policy at the University of Minnesota. And deep into the pandemic, he started publishing a weekly podcast, and his role as an infectious disease doc had a lot of these conversations. And I love the conversation you're having, because it's very similar to him. He's like, as a scientist, I shouldn't say this because I represent a strong Center for Disease Control. Is like, these dudes got it wrong on this. And, some of them have been things like that. The masking policy with just any type masks that are out there. He goes, the plexiglass dividers. And he's like, let me do this. He said, let me light up a cigarette on my side of the plexiglass and see if you smell it or not. And goes, if you can, then, it's possible you get COVID. If you can't, you can't. And so let's take a look. And so I think those are all valuable points. And, it's one of those things, I think, where, you're out there and providing such a strong, you're concerned that you're going to have, again, these 50 million deaths, again, going back to the Spanish flu, the numbers are unsure, but, one going up to 50 million. And nobody wants a disease like that to be on their watch. And so you come out with kind of a hard line, say, this is what you need. And then when evidence doesn't direct you, or when evidence does direct you, you don't shift because that seems to be an alteration. But, especially in our profession, we know that, with evidence-based medicine, if we've been doing something and it's proved that it doesn't work and we need to do something else, we now shift. And so some of those will kind of be interesting. But I will tell you, we've talked about it on here that, when I did have my case of COVID, mine, I just got tired, had a real short-term fever. It went away within 4 hours. And so, everybody's going to adapt just a little bit different. So, the key thing I think is, while the CDC does everything they can, take as much data that you have and work with your partners. This is one where, we have believe it or not, it seems like every physician that's out there is a researcher to some level. And, that's one of the things I think we miss commonly in this profession is an opportunity to say, hey, this is what I researched, let's take a look and add it up to a couple, go to our physician medical director and see if we change things a little bit. So one of the last topics I want to get to on here is what are you seeing as far as therapeutics? A lot of things are out there. We see the monoclonal antibodies. We see different treatments. What new treatments are out there, and what are you seeing as way for EMS to participate in that as well?
It's interesting that we're even involved in some of that stuff right now. I mean, we've kind of, COVID was a perfect segue for EMS to use some of our skills in areas where people weren't aware that we could do those things. Like people didn't know that we could give a shot, which is odd, but yeah, that's it. So, we've focused a lot on vaccines over the last year and a half, but in reality, in the pipeline for FDA, if you look at what's in development, there are probably 8 categories of things where there are literally several thousand therapies in development. And some of those are along the lines of antibodies, monoclonal antibodies, antivirals. Merck is probably the next one that's going to come out with something that is actually a pill that works very similar to the infusions of the monoclonal antibodies that we're using, which would be great because having to take a pill is a lot easier to swallow for some people, literally, than getting an infusion of something. But it runs the gamut of things from getting somebody who has the high-risk patient who is diagnosed with COVID and is at a high risk of going on to become seriously ill, to you and I, healthy people that, if we're exposed to COVID, is there something we could take that would head off the effects of that from being able to replicate in our bodies, and all the way down to these critically ill patients that we're putting on ECMO, because they're at the end stage of their illness from COVID. What could we do across that whole spectrum? And there are targeted treatments in every possible manner that you can think of that deal with the immune system and infectious diseases. Aside from vaccines, I mean, I think vaccines are like a tiny little portion of what's out there in development now. And it's fascinating because that's going to help us in other fields too. I think one of the things that people aren't even aware of is the mRNA viruses or mRNA vaccines, sorry. The Pfizer and the Moderna vaccines, that mRNA technology was designed to treat cancer. Actually, it was being used as a way of delivering therapeutics that were anti-cancer agents. And it has the capability to put 8 or 9 different things into one vaccine. So we could make an mRNA vaccine that covers the flu, that covers COVID, that covers measles, that covers mumps, and covers, whatever else you want to in one single vaccine. And that was the concept behind that when it was in development. And we've yet to even start to exploit that, but that's part of what's in the pipeline for the future.
It's one of those that they can attach kind of those chemical messengers and get directly where they where they needed to go. So really kind of interesting. So Chief, we've spent a tremendous amount of time talking tonight, and I've really kind of guided the conversation. So as we wrap up tonight, we always like to give an opportunity to just kind of give any parting thoughts that you might have out there. So any last thoughts for you today?
Well, I got a lot of thoughts all the time, but what I would say, let me circle back to talk about one thing that concerns me a little bit in the fire service. And I think that it might be applicable to what we see in the EMS world, the third service EMS world and commercial EMS world. We're in an amazingly good spot right now in the fire service because we have literally hundreds of chiefs that are running fire departments who came up through the ranks of EMS. And so now for the first time, I can actually say, when I talk about EMS things in a group of fire chiefs, that at least half of them get it. And that has, in addition to putting us in a better place on the fire side of the house, because chiefs understand, they came up through the EMS world, they understand that that's 80% of what the fire service does. And they have a skill set that centers around that, and they're good leaders, or they wouldn't have become the chiefs of the departments. They've left a vacuum in the middle. And so we're suffering right now in the fire service from those individuals who are really strong leaders, who had a skill set that developed on the EMS side of the fire service house, to move up to become the chiefs, and people aren't moving into those positions. So we don't have like a lot of bright minds in EMS in the fire service in the mid-level positions, in the company officer positions, and the district chiefs and battalion chiefs. And that concerns me. I'm just starting to become aware of that problem as I look for people to help with some committees on IAFC, and the IAFF is having kind of some similar problems on their side. But I wonder if that problem is not also present on the EMS side of the house when you look at commercial services, hospital-based services, and municipal services, third services. Is the really smart people are the leaders now, and they're doing a great job, and they've spent many years coming up through the ranks, but who's coming into their places in the middle? And I'm concerned about that. And I think that's something that all of us kind of need to think about a little bit is, and we talked a little bit about it earlier, is how do we develop leaders in the EMS services? And I'm very concerned about that. I think that that's something that we sort of missed over the last few years. And we've been happy about the folks from our ranks that have moved up, but we haven't really filled their positions. So that's something that definitely concerns me. And I think we got to probably spend a little bit of time looking at that. But the other thing I would say, just my 2 cents about the last year and a half and the hell that we've gone through is I'm really impressed with what has happened to the image of EMS in the United States and across the world, and the things that people have done, the flexibility and the thinking outside the box that EMS people have done. It is just remarkable to me. And I think there's a lot of good things that are going to come from this downstream. And so that's the thing that impresses me the most about the last year and a half, as bad as it's been for all of us.
Well, Chief, I certainly thank you. And I think you're absolutely right that, we should be taking a look and taking the opportunity to say, our people either need to push us to do better, or for us to get up and get out of their way and give them the resources and give them the opportunity, which is, it's kind of interesting. That's one of the reasons why we took on the title we have. We're the old guys anymore, and trying to hand off that knowledge to the next generation is like, learning how. And, so if you're listening to this and you're not quite sure where to push your service, like, hey, go over and pull down that IFC officer development plan, move that and design and implement, or not implement, but propose a EMS officer development plan and take it the direction that you want to go, and, make the service exactly what you want. But as leaders and mentors, guide and help those individuals out. So I'm going to toss it over to Bradley. Bradley's been quiet in the background. He did not Houdini us, or I guess ghost us, which is more like it. He's just been sitting in the background. So we'll give you the chance to talk on here for just a minute and give us your last thoughts today.
So I've got a couple. One of them is probably going to be something for the future that you just mentioned, the vacuum in the middle. But one of the big things is I will say this whole thing with the pandemic has caused a lot of stress, a lot of worry. One of the big things is create our daily routine and make sure you get plenty of rest for those of you that can. And then going back to the whole thing that he said there with the vacuum in the middle, that might be something we want to do for a future podcast, because I was just sitting here looking. I pulled up some various staffing things from a couple of agencies, and it looks like most of the people that are at the supervisor level and up have about 18 years and up. And then those that are assistants, roughly 7 or 8 years, and then everybody else in the agency is 5 or less years. So there is a huge vacuum in the middle. So good point.
I think that may be episode 2 with Chief McEvoy. You never know. We'll develop that, and so great points there, Bradley. How about you, Eric?
He mentioned my biggest pet peeve too for COVID, which was the fever. I just want to throw that out there.
Oh, yeah.
I work at a pediatric clinic on the side, and I can't tell how many positives we get back and they don't have fever. In fact, I'm starting to think it's more GI related symptoms and sinus infection symptoms before it's ever fever. So while we're routinely trying to diagnose COVID based off of that alone, heck, physicians are like, oh, you can't smell? Oh, sweet. We're not testing you. You got COVID. Stay home.
I went into a clinic. I went into a clinic to get a test done, not for COVID. And they took my temperature, and they weren't going to let me leave without significant treatment because it showed up as 103.9. And I'm like, let me just tell you, I feel like absolute crap when I go above 101, and I'm feeling like a champ right now. So you're going to have to come up with something else. And finally, they found an oral thermometer finally, and come back, and it was 98.7. I was like, yeah, see, you got to just, if I'm going 103.9, take your gloved hand and put it on the back of on my forehead. You'll realize that that's certainly not the case. That's hilarious. I completely and totally agree. So, Chief, again, we appreciate you coming on tonight. It's been a great episode. I think a lot of individuals are going to get a lot from this. So I look forward to getting everybody's feedback. But sir, thank you for coming on. And to all of our listeners, we always like to end by saying, hey, we want your feedback. And that's how we know exactly what you're looking for. So make sure to go by our website at emshandoff.com and give us a shout out there. Just to give everybody a heads up, as this is coming out, we're actually switching our Facebook from a group to a page. There's a lot of background work going behind that just to give you all a little bit more flexibility and kind of see us. We're going to have a lot more news coming out about that here in the near future. But don't forget to hop on over to our Facebook page as well. Facebook has been one of our most active areas, and we want to make sure that it's functional for you. We're going to keep both of them active for a while until we get everybody switched over. So it's not like we're dropping off our group right away. So make sure to go by and check us out. And if you haven't as well, go by our YouTube channel and hit the subscribe button so you get this every Wednesday at noon. And lastly, we like to make sure that you also like the EMS Handoff or EMS Today podcast by Jims, who broadcasts our audio every week. You can find them on Apple, Google, and Spotify. And don't forget to go by the Pursuit Company and get our gear, just because it's a cool thing. We want to see your pictures out and about. So make sure to give that a shout out. So From my co-host, Eric McCullough and Bradley Dean, on behalf of our guest as well, Chief McEvoy, this is David. Take care, stay safe, and always remember the value of your EMS handoff.